Oh,
I will.
I just want to actually. Don't think that there's nobody.
I was told there's about 80 people in the Zoom by the end, so I hope someone will prompt me if there are chat questions.
Yes. Hello, everybody. I'd like to welcome you all to Pediatric Grand Rounds, and I'm going to hand this off to Dr. Wadier to introduce our speaker today.
Hi there, I'm Rachel Wadier. I'm one of the faculty in Pediatric Infectious Diseases. The distinct pleasure of introducing my colleague and friend, Dr. Emily Levy, who is visiting from the Mayo Clinic. Dr. Levy is an assistant professor of pediatrics at Mayo Clinic. She has dual appointments in the divisions of pediatric critical care medicine and pediatric infectious diseases. She completed medical school at UCSF, followed by pediatrics residency and chief residency, and then went on to do a pediatric critical care fellowship at Boston Children's. And then upon appointment to faculty in Mayo, she actually had the unique training opportunity to complete a pediatric infectious diseases fellowship as well. And she currently serves as the physician lead for infection prevention at the Mayo Clinic and focused on critical care, cardiology, transplant, procedural subspecialties, and anesthesia. She's done a lot of wonderful work regarding the COVID pandemic, disaster preparedness, and she has an academic focus in pediatric healthcare associated infections, including central line associated bloodstream infections, viral sepsis, and she's going to be speaking to us today about severe lower respiratory tract infections related to influenza. Please welcome Dr. Levy.
Thank you so much for that kind introduction. Is the sound okay? Perfect. Thank you again for having me. Today, I'm going to be talking about influenza-related critical illness and strategies for severe influenza in children. My disclosures are as follows. The objectives of this talk are to describe prevention strategies for pediatric influenza, describe risk factors for morbidity and mortality from pediatric influenza, and to describe treatment strategies for pediatric influenza, including novel and combination antiviral management and the role of immunomodulation. We'll frame the talk around a case presentation of two different patients. Apple and Orange are both 18-month-old, fully vaccinated, ex-term healthy toddlers. Their family members have fevers and congestion, and they present to urgent care with fevers themselves. They're found to be mildly tachypnic, and they each have SOTS of 91% in room air. They both test negative for RSV on rapid RSV testing and are flu A positive on rapid testing. PO oseltamivir is initiated for them both for a 5-day course, and each of these children are admitted to the hospital for observation given their slightly low saturations. Patient Orange receives blow-by oxygen on hospital day 1 and is continued on PO oseltamivir, requires a little bit more oxygen on hospital day 2 up to 1 liter nasal cannula, and has improving saturations on hospital day 3 and 4. Patient Orange is discharged on hospital day 5 and recovers completely from her influenza over the next couple of days. Patient Apple also received blow-by oxygen on hospital day 1 and is continued on PO oseltamivir. She has worsening hypoxia on hospital day 2 and is escalated to high flow nasal cannula. She then develops higher fevers and lower saturations and is started empirically on vancomycin and ceftriaxone for concern for bacterial co-infection. She's transferred to the PICU for BiPAP on hospital day 3 and is intubated for respiratory failure the following day. Patient Apple then develops severe ARDS with PaO2s in the 60s on 100% oxygen and is eventually escalated to high frequency oscillation. Endotracheal and blood cultures result negative, and her vancomycin is discontinued by the infectious disease team that's following at this point. Ceftriaxone is continued empirically, and her oseltamivir is also continued past day 5 per the infectious disease team that's following. She's given IVIG empirically, even though she has no known prior immunodeficiency, and chest tubes are placed for new pleural effusions. Despite this care, patient Apple continues to progress with profound respiratory failure and is cannulated to VV ECMO on hospital day 6. She has stable hemodynamics throughout this time, and her chest X-ray is shown. So a couple questions about these patients. Why did patient Apple get so sick, but patient Orange didn't, when they appeared to have the same demographics and be very similar patients at the beginning of the talk? And now, how do we best medically support and treat patient Apple? Is there anything else we should have done differently previously? And what should we do now going forward? So as an infectious disease and critical care doctor, when I think about severe influenza, I think about this schematic and different factors that affect hosts developing critical illness with influenza. And this is really a helpful diagram that was published in 2015 related to ARDS, but I think holds true for all critical illness and influenza. I think about factors related to the virus itself, factors related to the host, and factors related to co-infection, particularly co-infection by bacteria, which we will talk about quite a bit in this talk as a known risk factor for severe influenza. And so I'm going to frame the majority of this talk around this Venn diagram, and we'll come back to it multiple times during the talk. Much of the discussion will focus on host factors, but first let's talk a little bit about the virus itself. So influenza virus is an enveloped, negative sense, single-stranded RNA virus with an 8-segmented genome. If you take those things each separately, what it means to have a negative sense RNA genome is that it has to be transcribed into a positive sense RNA before it can be translated into protein. And this leaves a lot of room for copy errors while influenza is replicating, which leads to the antigen shift that we see from season to season, and the reason that we get different influenza viruses every year. The 8-segment genome also leaves room for these genomes to kind of mix and match between different types of influenza strains, and that's sometimes called antigen shift, and paves the way for the pathway of different major subtypes of influenza to develop typically every decade or couple decades, that are often named pandemics, such as H1N1 was in 2009. There are 2 types of influenza that we see in humans: influenza A, which is classified by hemagglutinin and neuraminidase type. And although there's a lot of different H's and N types in mammals, particularly birds and swines, only H1 through 3 exist in humans, and N1 and 2. So there's a lot of mixing and matching of those combinations. And as I mentioned, influenza A is also classified by antigen drifts season to season, which gives us seasonal influenza that's different every year. And then influenza B, which also has an 8-segment genome and negative sense RNA, but typically has 2 consistent circulating strains that we know about, at least actively in humans right now, and is more prone to antigen drifts. Talk briefly about influenza epidemiology, first pre-COVID epidemiology, and then we'll wade a bit into what the COVID epidemiology has been like during seasons where they both existed. So shown here is the influenza burden in the United States. There's an estimated 290,000 to 600,000 seasonal influenza cases every year, seasonal influenza deaths every year worldwide. Here I'm showing the burden in the United States. The grays are illness, the yellows are hospitalizations, and the reds are death. And you can see that while there's some variation season to season, since the 2009 swine flu pandemic, things have been about stable until 2020, which was when COVID initially emerged. 2019 through 2020 was a pretty typical influenza year. This graph shows influenza per 100,000 population by age. And so in the lowest line, that's the 0 through 4-year group, and the upper red line is 65 plus. So you can see that influenza affects older people more than it does affect children, but it does affect children. Those 3 bottom lines are all pediatric age groups. Shown here is 2021 through 2022. both because there was hardly any influenza at all, 2019 through 2020, and because we don't have surveillance data from that year because our surveillance entities were so busy with COVID-19. Here in 2021 through 2022, you can see that there was a bit of an unusual influenza year as we were still in the midst of the peaks of the COVID pandemic. And then shown here is this year, 2022 to 2023. And while the peak of influenza was a bit earlier in the season than we typically see, so a bit shifted, it was very similar in terms of rates overall of deaths, hospitalizations, and overall cases of influenza. So influenza appears to be back and here to stay as a seasonal illness. Let's talk about severe pediatric death cases, which is what we're interested in as the topic of this talk. This graph shows 2017 through 2023 deaths by age group, with the lowest age group in the turquoise on the bottom. Again, skipping 2021 skipping one of the years that we don't have surveillance data for. And then over to the right, the surveillance data that we do have is shown. You can see that in 2020 through 2021, there was only one pediatric death in the country reported for influenza. But now as of 2022, 2023, we're back to nearly what we were in the 2018, 2019. So about 140 pediatric deaths. Why do we have less cases of influenza during the peaks of the COVID pandemic? This is probably a dual etiology. It probably came from the fact that masking is extremely helpful to prevent influenza spread. And so when people reliably masked, we saw significantly less influenza. It spread almost primarily by droplet transmission. And the other theory, which I think is probably also true, is that COVID outcompeted influenza when COVID was very active and when people were getting really sick from COVID. And once you had gotten really sick from COVID and were at home and by yourself and sick, you didn't have the opportunity to get and then spread influenza. We'll spend some brief time on prevention. So the seasonal flu vaccine, which I've mentioned a couple times so far, protects against the influenza virus predicted for the upcoming season. And this is guided by the ACIP, which tries to make their best guess about which strains we'll see and which antigen shifts we'll see in the upcoming season. It's recommended for kids older than 6 months old, and 2 doses are recommended in the first year. Currently, all United States vaccines are quadrivalent. That means they cover 2 A viruses and 2 B viruses. And the 2 A viruses that we've had since 2009 in terms of subtype strain are H1N1 pandemic and H3N2. And when we're making guesses about which viruses we'll see for the upcoming season, they're making guesses about small antigen drifts in those viruses. And then they cover the 2 most common influenza B viruses as well. They're adjusted yearly. And then there's a nasal spray option, which is a live attenuated vaccine for immunocompetent kids 2 through 49-year-old adults. There are 2 egg-free options. So most flu shots, including the nasal spray, are manufactured with egg-based technology. People with egg allergies can receive any age-appropriate flu vaccine, but most of the time people with severe egg allergies or anaphylaxis from eggs will initially choose to give them one of the 2 egg-free options. And certainly if they have a severe egg allergy, they should be observed after any flu shot. If they've ever had a reaction to a flu vaccine with egg in it and are known to have an egg allergy, at that point, egg-free vaccine options are recommended, and we would again observe those patients after any flu shots. So we talked about prevention for all comers, but do vaccines prevent life-threatening influenza illness? I'm showing here a couple studies showing that they do. And so children who were fully vaccinated in this 2011 study were less likely to be admitted to a PICU for influenza than those who were not fully vaccinated. And 1 dose of vaccine for children where 2 doses of vaccine were recommended was not protective. And then I'm also showing a diagram from the CDC here from the 2008 through 2018 flu seasons, showing exactly how effective the vaccines were. And you can see that normally we're pretty good at guessing what seasonal shifts we'll see in the vaccine. And we try to hit about 50% efficacy for preventing disease. In terms of influenza diagnostics, the most common diagnostics right now are molecular assays. These are either a rapid PCR or traditional PCRs. We also have cell culture, which is a good method to quantify burden of influenza, but cell culture is slow and it's not as useful clinically most of the time. So we've talked about prevention and diagnostics, but now let's get back to kind of the center of this talk, which is who are the critically ill children who develop influenza? And going back to that case at the beginning, why did patient Apple get so sick with influenza? I'm going to be talking a lot about the PICFLU trial. The PICFLU trial was a trial that I participated in both at Boston and then from the site that I'm at now, which is Mayo Clinic, and looked at all-comer children who were admitted to United States PICUs with influenza. So an initial 2011 publication looked at mostly H1N1 and found that over 70% of these kids had a chronic health condition if they were being admitted to a PICU for influenza. And as pediatricians, this isn't completely surprising. We know that kids who are technology dependent or medically complex are more likely to get sick with a number of infections, including viral illnesses like influenza. And if you have an underlying immunodeficiency or respiratory condition, you're probably more likely to get very sick. What about the patients in the other 30% though? So as PICFLU proceeded, we had about 10 years of data, and there were 226 previously healthy children, so that other about 30% who were admitted to PICUs with confirmed community-acquired influenza after having no underlying illness. And 17 of these children died. Both studies showed that early MRSA or bacterial co-infection was the major risk factor in death in all children, including children who are previously healthy. And in multivariate analysis, this was one of the only factors that really emerged for death in the previously healthy child group that could be teased out as a risk factor. Older patients, those kids who were more than 10 years old, especially those who had been previously healthy who died, were more likely to have bacterial co-infection. And even in the younger patient group, about 50% of the very sick kids or kids who passed away also had bacterial co-infection. There was no difference in mortality based on influenza subtype. And the other risk factors that we saw for mortality were related to critical illness. So kids who had myocarditis or ARDS when they presented or shock, those patients were more likely to pass away. So there's been a number of publications related to the influenza data and the PICFLU data, and I don't have time to go into detail in all of them, but I'm going to share some of the influenza support strategy and summary lessons we learned here. Which is that identifying critical illness pathophysiology and targeting support strategies based on that works really well for severe influenza illness. And so what does that mean? If the patient has shock, treat their shock. If the patient has ARDS, treat their ARDS. Co-infections should be addressed early and aggressively, and this is a theme we'll see throughout the talk. That was one part of that three-part Venn diagram, and now we've seen that in children who are critically ill, co-infections are a major risk factor for death. Another finding we saw was that patients who were put on ECMO early had much lower risk for long-term lung injury than patients who were put on ECMO late, who ended up needing ECMO for ARDS. And so the clinical takeaway from this would be that if a patient has severe respiratory failure and is seeming like they may need ECMO, it's good to consider ECMO early in that course, and specifically within the first 7 days of them becoming critically ill. This talk wouldn't be complete in 2023 without talking a little bit about the co-pandemic of COVID and flu that was predicted to happen this year. And we really didn't see this. So we didn't see a lot of viral co-infections with either RSV or influenza, RSV or COVID or flu, but there was a lot of concern about it. What we did see was simultaneous COVID in some children and flu in other children, and a fair amount of data at this point about kids who are critically ill with COVID and kids who are critically ill with flu. And so I know there are a lot of trainees present for this talk, and many of you have seen mostly COVID over the past 3 years. And so I wanted to take the opportunity to highlight this study that I participated in with Halasa and colleagues that was published in 2023 that contrasted influenza and COVID presentations. And I think this is useful, especially when many of us are used to taking care of kids with severe COVID right now, to just remind us what the severe influenza population looks like. So this study looked at kids who were admitted with severe influenza to ICUs versus kids who were admitted with severe COVID-19 to ICUs, and these were all previously healthy kids. The kids who were admitted with influenza were on average younger. They were more likely to be from a Hispanic population. They had less underlying conditions and were less medically complex than the COVID patients. They were less likely to be obese than the COVID patients. And from a laboratory standpoint, they had higher neutrophil to lymphocyte ratios than the COVID patients. Kids with severe influenza also were more likely to be stabilized first on non-invasive support, but they had similar mechanical ventilation amounts to kids with COVID. They had generally shorter lengths of stay, but higher severity than the patients with COVID who were in the ICU. And coming back to that theme we've mentioned a couple of times now, they had more bacterial co-infections if they were presenting with influenza and critical illness. So let's talk a little bit about influenza therapies and the three, going back to that 3-factor approach that we've discussed a couple times. Therapies can be targeted at all areas of that Venn diagram. So antiviral medications targeting the virus itself. And I'll just make a quick note here that amantadine is really not used anymore because there's widespread resistance. So I'm not going to touch on that antiviral very much. Treating bacterial co-infections or co-infections themselves, and then host immunomodulation, which I'll get to near to the end of the talk because it's a more complex category with a lot of conflicting evidence in it. So at first, just to talk about antiviral medications, the most widespread class of antiviral medications are neuroamidase inhibitors, or NAIs. And recall that the NA proteins mediate viral release after replication in influenza A and influenza B. And so NA inhibitors, NAIs, block the virions from replicating more virus for release from the cells. They target both influenza A and B. There's a PO NAI, also tamivir, which I mentioned earlier. This has been evidence proven to reduce durations and complications. It has rigorous evidence in outpatient, and there's a fair amount of evidence that it can increase survival in hospitalized patients. It's typically BID within 5 days. Sharice, is there anything I should do about that? Okay, I just wanted to make sure it's not something from the projection. Okay, it's typically BID for 5 days, but there are a number of studies that show that it could be considered for longer duration than 5 days in critically ill patients, and that for patients with prolonged viral shedding, for instance, patients who are severely immunocompromised, continuing the duration beyond the 5 days may actually have a clinical benefit. You can see here over to the right a graph that I just want to highlight by Louis and colleagues, which is published in Pediatrics in 2013. And the point of this is just to show that oseltamivir really works the best when it started within the first 48 hours of illness. So what they're looking at is the number of kids who died and when Tamiflu was started. And the least number of kids died when it was started within the first 48 hours of illness. And if it was started a couple of weeks into illness, it really doesn't work at all. And that's probably because most of the critical illness or morbidity or mortality as you get a couple weeks into influenza is probably being mediated by the host system itself. So host inflammation is probably causing most of the damage. There are 2 IV agents that are also NAIs, zanamivir, which is available IV and inhaled, and peramivir, which is only available IV. These are often used when patients have poor PO intake or are not able to tolerate PO, but they can also be considered for rare oseltamivir resistance. And we do sometimes see oseltamivir resistance, but it's really not very common these days. We also sometimes see patients develop resistance after they've been on prolonged courses of oseltamivir. So it's something to think about, but something that we don't see very often. Next, I'm going to talk about baloxavir, which is a newer class antiviral. It belongs to, it's a novel agent in its own class that inhibits viral assembly by blocking transcription. And so while it also blocks more virus release, it works in a completely different pathway than NAIs do. It's also PO, but appealingly, it's a single dose, so not BID over 5 days, but just a single dose of baloxavir, ideally at the beginning of when you're ill. It targets influenza A and B, and it's currently FDA approved for kids who are older than 5 years old, within the first 48 hours of illness, ideally, or for PEP in select populations. So post-infection prophylaxis or post-exposure prophylaxis in certain groups of patients. This is a medication that can be considered if you're thinking about NAI resistance in your patients, but it also has appealing potentials for other populations, specifically populations that may be less compliant with taking a medication BID for 5 days. For instance, some of our adolescent populations, it's really appealing that you could give a single dose of this medication. Initially, there was a lot of enthusiasm that baloxavir might work better than NAIs, but multiple studies have shown that likely not to be true at this point and that they're likely equivalent. So an initial study in the New England Journal in 2018 showed equivalent benefit for adolescents and adults to NAIs. This study shown to the right of the screen was published in 2020 and looked at kids 1 through 12 years old, comparing single dose baloxavir to oseltamivir BID for 5 days, and showed essentially equivalent safety and benefit for otherwise healthy children between the two medications. And there's an ongoing funded NIH trial for those under 1 year old, so stay tuned for future results, but I wouldn't necessarily expect this medication to be more effective in that population than NAIs are, since we haven't seen that in any other age groups. So if it's not better than NAIs or used instead of NAIs, what about using it in combination therapy, especially for really critically ill patients? This is an appealing idea because these medications target 2 different pathways of virus release. And so we often think about dual therapy in really sick patients with infectious diseases. This study enrolled adolescents 12 years and older hospitalized with influenza, and they randomized them 2-to-1 to baloxavir plus NAIs versus placebo plus NAIs. And they saw no difference in clinical improvement time. So it really didn't help to give both the medications together versus just the standard of care, which is NAIs, in terms of when these patients were discharged from the hospital or how well they did. But they did see an interesting finding when they looked at viral culture, one of those modes of diagnostics that we talked about earlier. And that was that adding baloxavir, so dual therapy, shortened the time of viral shedding. And that does have some clinical implications that we may want to think about, particularly for patients who have prolonged viral shedding, like those who are immunodeficient or who we know. Sorry for that. Thanks, Therese. Particularly for kids who are immunodeficient or have prolonged viral shedding as part of the reason that they're, or as part of the etiology of their critical illness. Maybe if adding dual therapy reduces the time of viral shedding, it may have clinical implications just in that specific population. And the population looked at in this study was all comers 12 years or older, so it didn't target an immunodeficient or immunocompromised population. The other potential area that it brings up is infection control, which is one of my passions. And so viral shedding is associated with when patients are infectious. And it may bring to mind that if you can shorten the time of viral shedding, you may be shortening the time that the patient is actually infectious, which has implications for infection control. So while we haven't seen a clinical benefit of this yet, we do sometimes combine these therapies, particularly in critically ill patients, and it would be something that I would think about as an ID doctor in an immunodeficient population. Let's shift now to talk about one of the other areas of that Venn diagram that I've mentioned a couple times, which is bacterial co-infection. So as I mentioned earlier, this emerged as one of the main risk factors for previously healthy kids who were hospitalized with influenza dying. Looking over at this bar graph, which is from a study by Randolph and colleagues in 2019. What I want to draw your attention to are those black bars, which are influenza and MRSA or MRSA co-infection. So the black bars are influenza and MRSA co-infection. The gray bars are influenza and other bacteria, and the white bars are influenza with no co-infection. And you can see that for acute lung injury, vasopressors, ECMO support, and mortality, it wasn't just co-infection that led to worse outcomes in all of these areas. It was particularly MRSA co-infection, which was an interesting finding because it's a specific bacteria. When we think about what other bacteria these patients have, this is from a study that I published looking at the same PICFLU population. And while MRSA was the only bacteria type that was correlated with death, we did see that the second most common bacteria type was MSSA. Then we saw some strep pneumoniae in these patients as well. And then the other bacteria group did include some gram negatives like Pseudomonas, which we typically see in ventilated patients, so a healthcare associated infection. This study, which was published in 2019 by some of my colleagues, looked at how to treat specifically the patients who had confirmed MRSA co-infection. So this was 34 pediatric intensive care units. And while the N was small, it was only about 30 patients. They were all critically ill with confirmed MRSA and influenza co-infection. And interestingly, death was more than fivefold in the patients who vancomycin monotherapy was used in. So to the right, you see the graph of fatal patients, and that white section of the bar is vancomycin monotherapy. This was compared to if a second MRSA agent was used, and that second MRSA agent was typically clindamycin. This was just a retrospective surveillance study, so it was whatever the clinicians had chose. Sometimes it was linezolid, which is that checkered bar graph. And so this was a pretty interesting finding that wasn't necessarily expected, and there's been a number of editorials and theories related to it. But what we know is that patients who received vancomycin monotherapy had a much higher rate of dying in this study. The theories behind why that may be, so I think one thing we take from the toxic shock literature is that toxin-mediated illness and effect are best addressed by antitoxin antibiotics or protein antibiotics that inhibit protein. And so clindamycin and linezolid are two of this class of antibiotics. And perhaps there's a toxin-mediated effect in these patients that we've underappreciated. So just like toxic shock syndrome, perhaps these patients also need an antitoxin therapy. Another theory is that the vancomycin may not have had appropriate levels in some of these patients because vancomycin relies on troughs, as many of us know. And MIC information was unavailable for almost a third of these patients, but median troughs of vancomycin were similar in both groups. So it's hard to blame this all on inappropriate troughs. Now, in the last section of the talk, I'll talk about host immunomodulation, so that third part of that Venn diagram. And as I mentioned a little bit earlier, this tends to be the most controversial topic, both because there's not very strong evidence about many of these medications and because the evidence is mixed about many of the medications. So first, steroids, our oldest and most commonly used host immunomodulator. Mixed evidence about use in influenza, but the evidence that we have tends towards steroids causing harm. And particularly, it's been shown that steroids early on in influenza illness can lead to prolonged viral shedding in these patients, which we know can be correlated with more prolonged illness. And so right now, steroids are not recommended unless they're aimed at a specific sequelae. So if the patient has severe ARDS and the ICU would be using steroids for that type of ARDS, steroids could be used then, or if the patient has asthma and bronchospasm and steroids would be used for that type of bronchospasm, that would be a time where you would use steroids, but you wouldn't use them alone just for influenza. Cytokine therapy, so that would be your anti-IL-2, things we talked a lot about with COVID, which rely on kind of the theory that the host immune system is causing much of the damage, have no evidence of benefit in critical illness with influenza. And while harm hasn't been shown, there's certainly the potential for harm every time you suppress the host immune system when they have an infection. FFP or general pooled IVIG. So I mentioned at the beginning that our patient Apple actually received IVIG. There's no evidence of benefit for this, although in theory, you can imagine that giving someone antibodies against the illness that they had would be helpful. In practicality, most of our pooled population IVIG doesn't have specific antibodies to that year's strain of influenza, and we haven't seen benefit for general IVIG in this population. So if IVIG from the general population doesn't work, what about targeted antibodies? So this would be your high titer immunoglobulins where someone has specifically selected for anti-flu immunoglobulins, or donor-directed therapy. So a parent and a child have the same type of illness from the same presumed strain of influenza, and the parent donates antibodies to the child. We call this convalescent plasma during COVID for those of you who took care of critically ill COVID patients. And while, again, it's appealing, there's not real evidence that it works yet. And I'll talk about that a bit more on the next slide. And then other immune repletion. So repletion of different other types of the immune system. We'll talk about this in greater detail in a bit, but it's there's not any proven evidence that this helps. So just talking briefly about passive immune therapy with targeted antibodies. This has been a very appealing area of inquiry for years, over 30 years of research into this in the attempt to find anti-influenza antibodies, either from the population or from directed donation or from creation that could creation de novo in a lab that could work for critically ill kids with influenza. And this large meta-analysis that was published in 2020, the kind of summary line is that they likely don't work. In the top section above the first red line, you see 5 randomized controlled trials, the largest and most rigorous of which was probably Davey and colleagues in 2019, which really didn't show any significant clinical benefit for high titer flu IVIG, so immunoglobulins that's enriched for the specific flu the patient had. There was some potential clinical outcome in a sub-analysis of this, which you see on the lower half of this under B at day 7 when clinical outcomes were assessed using a particular scale. But it wasn't enough of a conclusion that any recommendation came from this meta-analysis to consider IVIG. It was something that could be looked at further in terms of clinical outcomes, but really there's not significant evidence, even in meta-analyses, that this works right now. And so until we have more evidence that it does, it's not recommended. It's also clunky and time consuming to get specific flu antibodies and expensive for something that we really don't have good evidence for. I'm going to talk a little bit about my own ICU fellowship research, which was done at Boston as an example of a particular type of innate immunity repletion you might consider. So that last category where you're repleting a different type of the immune system. So mannose-binding lectin is a protein in the innate immune system. It activates complement via the lectin complement pathway. It, in theory, could protect against influenza via glycosylation recognition, direct neutralization, or by targeting bacterial co-infection. The lectin complement pathway is one of the most active complement pathways for recognizing bacteria. But despite in vitro and some mouse model evidence that MBL could target influenza, clinical studies have had mixed results so far. Appealingly, recombinant MBL is available and has been shown to be safe for humans in phase 3 clinical trials. So if some benefit was shown from MBL, this would be something that would be available that we could get to kids. So low MBL serum levels and activity are associated with known polymorphisms in the gene. Shown here are 2 polymorphisms in the promoter of the gene, which lower serum levels, and then 3 polymorphisms in the exon, which lead to transcription of either lower MBL levels or misformed proteins. And this gene is transcribed into a monomer protein, which then assemble into trimeric subunits and circulate in the serum as oligomers. This study also used the PICFLU population. And so patients were enrolled from 38 pediatric ICUs from 2008 through 2016. They were children under 21 who were critically ill and influenza positive. And we looked at how MBL might affect critical illness with influenza in a couple different ways. We tried to see if patients would be more susceptible to influenza or more susceptible to critical illness. And in the first part of this study, we verified that the genotypes with the low producing genotypes actually correlated with what we expected in the serum level. So we genotyped these patients and then we measured MBL and their serum levels to show that low producing haplotypes did lead to low serum for MBL. And we also looked at in vitro lectin pathway activity. So we made sure that patients with low serum MBL or the low producing genotypes actually activated the lectin pathway less. Then we looked at susceptibility to influenza, and we did this in two ways, through a genetic analysis where we compared the kids with critically ill influenza to healthy controls to see if the kids with critically ill influenza had more of the low producing haplotypes than healthy controls would. So is this population enriched for a genotype that has low producers in it? And we did what's called a family-based analysis where we looked at parental trios in children to, again, try to see if the child population with critically ill influenza was enriched for certain genotypes. We also did a severity analysis looking at low producing haplotypes and different types of severity. So as expected, the genotypes predicted serum levels. So patients with low producing genotypes shown over to the right of the screen here had lower serum levels of MBL. And this has been shown in multiple other studies. The low producing homozygotes had minimal lectin pathway complement fixation. So the low producing genotypes for MBL actually did lead to less innate immune activity and less complement activated in those patients' serum. MBL was not associated with influenza-related critical illness susceptibility. So you'll recall we looked at this in two ways. We compared our population of kids who are critically ill with influenza to a healthy population, and frequencies did not vary significantly between those two populations. So there were the same number of low producing haplotypes in both populations. And then we did that family-based analysis with parents with the same result. There wasn't enrichment in the influenza critical illness population for these low producing haplotypes. MBL2 variants were not associated with admission illness severity, septic shock, or ALDS, ARDS, but specifically the low producing B allele variant was associated with death in the population. And so I'm going to show you a couple pie charts here. In gray are patients who had 2 copies of the low producing B allele, and that's an exon mutation that leads to less MBL and less MBL activity in the serum. In blue are patients with 1 B allele and 1 wild type copy. And then in green are patients with no B. And you can see in this first comparison that patients who died versus patients who survived, the patients who died were much more likely to have a B allele. We knew that MRSA was a risk factor for death in these patients. And so we tried to see if the patients who had MRSA co-infection with were more likely to have a B allele, and there wasn't any difference in that population. But again, when we looked at death, patients who had influenza and MRSA and died were much more likely to have a B allele than patients who had influenza and MRSA and survived. So why might this be? The B allele specifically in the MBL exon has been associated with impairing oligomer protein stability. So when we talked about this innate immune protein initially, we talked about how they circulate as oligomers, and even having 1 B copy has been shown to destabilize that oligomer, even if some of your proteins are the wild type protein. And so perhaps patients who are reliant on innate immunity are particularly reliant on these circulating oligomers, and destabilization of them predisposes them to more severe influenza, including death. We also found in a multiple linear regression model that carriage of the B allele showed risk of mortality, which at this point we expected, and that anti-MRSA monotherapy led to risk of mortality, which we knew from that prior study, but that the combination of the two factors was actually worse than we expected for additive. And so why might that be? That might be because lack of antibacterial therapy or perfect antibacterial therapy could leave children more reliant on innate immunity. And so if you had dysfunctional innate immunity for a certain type of illness, specifically MRSA co-infection with influenza, you might be more likely to die, especially if you didn't have certain antibiotics on board that you might need. So in conclusion about the specific innate immunity factor, we did find that genotypes strongly predicted serum levels and complement activation, and that the genotypes and therefore baseline levels and protein activity were not associated with influenza critical illness susceptibility. But carriage of the B allele may be associated with increased risk of pediatric influenza death, particularly in children with influenza MRSA co-infection. And so these findings could support potential testing of MBL repletion in children with influenza critical illness, particularly in those with the B allele. But there's really limited technology currently to assess what patients' MBL haplotypes are, especially as they're critically ill and being admitted to ICUs. And there's limited ways of getting MBL repletion to these patients. So while this is an interesting theory, it would need a lot more clinical investigation before we pursued it as a clinical therapy. So stepping away from treatments for MBL, let's step back to our initial patients and close the loop on patient Apple. You'll recall from the beginning of the talk that patient Apple was the child who was 18 months old and previously healthy and developed critical illness from influenza, ending up on VV ECMO. And we asked a couple questions at the beginning of the talk. Should we have done anything different caring for her, and how should we care for her going forward? So just to close the loop on patient Apple herself, she received a tracheostomy and was decannulated from VV ECMO after 2.5 weeks. She had a long recovery in the PICU, which was complicated by renal dysfunction, but she was discharged home and she was decannulated 1 year later, and she's currently thriving in elementary school. And I took care of this patient more than 5 years ago now, so it's been quite a while since she was critically ill. Now, what have we learned from this talk about recommendations for severe influenza-related critical illness? So I'll summarize these in a couple points. Neuraminidase inhibitor therapy should be started as early as possible, if you recall that graph that we looked like. And if patients are critically ill, you should consider extending the course beyond 5 days. Baloxavir could be considered depending on risk, demographic, and severity of the patient. That's that other antiviral that targets a different mechanism of viral replication. And this is a good opportunity to consult your friendly PedsID colleagues, as they're going to be most up to date on the forthcoming research about baloxavir and about combination therapy. Bacterial co-infections should be treated early and aggressively, particularly MRSA. It's certainly not proven that dual therapy is needed for MRSA influenza critical illness, but I do consider it in my own practice when I have a patient with influenza critical illness based on that study we talked about and the possibility that we're seeing toxin-mediated effect as part of this illness. Supportive care should be optimized, including mechanical ventilation and early ECMO support for patients who are likely to require ECMO support. We should try to avoid steroids early in illness with influenza and use steroids only if they target a particular critical illness symptom or etiology that the patient has, like bronchospasm. And currently there's a limited role for IVIG, convalescent plasma, or any of the types of targeted immune repletion we talked about, including specific anti-flu, IVIG, or other innate immune repletion, given present diagnostics and available therapies. But it's an actively evolving area and definitely something to keep your eye on, and recommendations may change in the near future. I want to take a second to acknowledge everyone who contributed to much of the research shown in this talk. As I mentioned, I'm part of the PICFLU and Overcoming COVID trials, but a very small part. I specifically want to acknowledge my mentor, Dr. Randolph from Boston Children's Hospital, who helped me and mentor me through much of my own fellowship research, and then all of the sites that contribute to Overcoming COVID and PICFLU, including UCSF, which has 2 contributing sites and contributed many of the patients for the studies that I talked about here. And thank you so much for having me and for all you do for patients. I wanted to show this picture at the end of the talk, which is me and my co-chief Amanda Sanders at Mission Bay before we moved in 2014 from my own chief year. And I'd be happy to take any questions in our last 10 minutes here. Dr. Wadier.
So thank you for giving a talk on influenza, because I think it takes the ID division off the hook in that we did COVID and we did an RSV talk in the winter, and so we hit like all of our big respiratory viruses. But in the RSV talk, there was a lot of really interesting observations about disappearance of RSV strains during COVID and reemergence with very different genetics. And I'm curious, I think I know that some flu strains may have disappeared during COVID. What are your thoughts on how that affects what we may see in the next few years with flu?
Yeah, it's a really interesting question. Just to repeat it for those online in case they couldn't hear, the question was, for RSV, we saw a kind of disappearance of some strains and emergence of new strains related to the timing of the COVID-19 pandemic, and have we seen something similar for influenza? So interestingly, H1N1 made it through the COVID pandemic and seems to be here to stay, as I mentioned, and that H3N2 subtype has also been around pre-pandemic, but we have seen a decrease in a number of other less common strains, as well as some emerging concerning strains, particularly in avian populations. I think, as I mentioned, anytime you have a new pandemic with a new virus that's very contagious and that many people get, it's going to really affect the evolution of other respiratory viruses in the population. And so I don't think we know all of the effects it's had on influenza yet, but I think we'll begin to see, once we have more of a retrospective perspective, that there were some major changes in the way influenza was acting. And the biggest one we can point to now is that influenza emerged much earlier in our most previous season. And so what that meant that we should have been vaccinating kids for influenza much earlier, but we didn't necessarily know that was going to happen at the time. And so the timing is something to definitely keep an eye on also. Dr. McNamara, hello.
It's great to see you. So you spoke quite a bit about the risk factors for severe disease and death related to influenza with bacterial superinfections, and I'm wondering, this is perhaps a little off script or tangential, but I'm wondering if there is understanding yet that is emerging about differential factors that relate to bacterial superinfections playing such a role with the complications in influenza when we're not seeing that.
That's a really interesting question. So the question was, bacterial co-infection or superinfection has been long understood as a major risk factor for morbidity and mortality in influenza. And I talked about that quite a bit. And when COVID started, we expected to see the same thing in COVID. And there was a lot about that, including a lot of early guidance that recommended empiric antibiotics for adults and children who are critically ill with COVID. We just didn't see that. And I don't think we know the pathogenesis of why that is, but we do know now that most kids who are critically ill with COVID do not have a bacterial co-infection. I would get, this is pure hypothesis, but I would guess that that's because there's slightly different mechanisms for critical illness in the two viruses. So a lot of the COVID critical illness comes from the host immune system itself. That's why we saw, the 7-day admissions or the 10-day admissions, where it's actually the host inflammatory response to COVID that's causing most of the lung damage and the critical illness. Whereas in influenza, while there is some host mediated kind of inappropriate response, and a lot of the damage we see may be in part due to inflammation, much of the critical illness is due to the actual viral damage itself and things that glom onto it like bacteria. And so there's less of that kind of very long course that we see in COVID, where it's the host immune system itself that's starting to cause most of the damage. That's just a theory, but it would be something I would think about.
Question about the severe critical illness with co-infection that were on Alleles. I'm thinking of back during in the 2010s. You said early ECMO is good, like they did better. As you were talking, I could think of a few patients that I know didn't survive.
Yeah, so the question was about, a lot of the mortality and morbidity that we saw in influenza, especially in previously healthy kids, is in kids who present with shock, with septic shock, and if ECMO improved outcomes for those patients too. I don't think we have the numbers. I would say clinically, supporting a septic patient with VA ECMO is the standard of care, and it sometimes works and it sometimes doesn't work, unfortunately. We did see overall that the earlier patients were transferred or that critical illness was addressed, the better they did. So there's definitely evidence that if a patient is developing shock, getting them to a center with ECMO capability and an ICU is likely going to be better for that patient's outcome. But once that patient's on VA support for septic shock, I think they probably fall into kind of the group of patients who are on VA support for septic shock, which is that it can go either way. Yeah.
It's not a question, but a comment. It's from Steve from the city. He says, thanks, Dr. Levy, for a very nice talk. 3 comments. 1, IV Zanamivir is not available in the US. It's not available. 2, Susceptibility is well absorbed in critically ill patients and given via NGOG2. 3, the RENAT-CAP clinical network trial platform is studying immunomodulators in severe influenza, including corticosteroids, IL-6 receptor blockers, and JAK. Fingers crossed that data might show some influenza for these patients.
Awesome. Thank you. Thank you so much. I'll repeat some of those comments just in case people couldn't hear because they're important comments. So the first one was that zanimivir is not available in the United States right now, which was one of those NAIs I mentioned. The second is that so I said to consider IV NIIs if your patient isn't tolerating PO, which is a little bit of ICU talk, but they don't have to be eating by mouth to tolerate PO, but sometimes we do get critically ill patients who aren't getting any enteral absorption. So if you have an NG and are feeding the patient that way, the comment was that oseltamivir can be well absorbed and still effective in those patients. And then I think that third one was just a comment about ongoing trials for baloxavir and other antivirals. And we certainly could use some better and newer antivirals and also some evidence that combination therapy works. So really appreciate the comments that commenter made. Anything else in the chat we should know about? Okay, well, thank you again for having me. It's been a really great time visiting UCSF this week, and it's really nice to see some familiar faces in the audience.